Thank you so much. We're going back to England. we are going to listen to Michael Biggs. You're a senior lecturer in sociology at Oxford University. You have published a lot on the subject, which are really interesting papers. So we are very happy to listen to you. Also on the same question, on how can we understand that the trans child theory has spread worldwide with the Dutch protocol on the simple basis of a cohort study of 70 patients?
Thanks very much. For some reason, I'm losing my voice, so I'm probably going to sound a little bit like Joe Biden. Just to remind us, the Dutch protocol involved the suppression of puberty from the age of 12 or even younger, using gonadotropin-releasing hormone agonists as the first stage before cross-sex hormones and surgery. And this became standard practice at the Amsterdam Gender Clinic from the beginning of the 2000s. So why did this Dutch protocol spread worldwide? So first we can look at the supply side. The Dutch clinicians like Peggy Cohen-Kettenis were already prominent in the field of transgender medicine, which was then a very small niche field. And so, for example, they were on the board of directors of the World Professional Association of Transgender Health, WPATH. So it was natural then that they could get puberty suppression into the WPATH standards of care, first appearing in 2001 and the edition in 2001. So the Dutch protocol was embraced by some enthusiastic clinicians elsewhere. An example is Norman Spack, a pediatric endocrinologist in the United States. And he recalls salivating, like literally, at the prospect of treating patients with puberty blockers. So in 2007, he co-founded the Gender Management Service at Boston Children's Hospital, which was the first dedicated clinic for transgender children in America. And as Gilles said, this is sort of this direct export because they sent psychologists over to Amsterdam to sort of learn the Dutch protocol directly from the Amsterdam clinic. Even in countries where clinicians were reluctant, puberty blockers were demanded by patients and their families. This was the case at the clinic in London, which has become infamous as the Tavistock Clinic. So its founder, Domenico Di Cellier, although he was a psychiatrist, really emphasized psychoanalytical support and did not provide physical interventions for children under the age of 16. But it was the parents of children who mobilized and campaigned for the use of puberty blockers. They denounced the cautious clinicians as transphobic, and that's one of the first uses of the word transphobic in the press. And some of these parents even took their children to Boston to buy private treatment from SPAC. And so this pressure was overwhelming, and so the Tavistock got a new director, Polly Carmichael, who in 2010 then started experimental treatment with puberty blockers from the age of 12. And so what's remarkable in the history that I've just recounted very quickly is that the international diffusion of the Dutch protocol before 2011 was based on the evidence of only a single patient who had been followed up only to the age of 20. So this is before even there was that study in 2011. Finally, we can then consider the other side of the equation, the demand side. So why were there an increasing number of children and parents seeking this intervention? And I think one crucial feature was the positive media representations of transitioning children. And this began really very surprisingly early. So in 1996, an English television documentary took a trans child aged 13 who was trapped in the wrong body, and that was the name of the documentary, The Wrong Body, to the Amsterdam clinic. And the film ended with the London clinic, the Tavistock, refusing to give puberty blockers. And then the Dutch endocrinologist, Louis Horen, on the telephone, was telephoning the mother and said, I'll prescribe them to you. We can do this in the European Union, I'll prescribe them myself. I'm quite amazing seeing they'd only seen this child in the course of making the documentary, but was still willing to prescribe puberty blockers. And this documentary was watched by 3 million viewers in Britain. And subsequent documentaries across the world sort of have followed the same pattern of following adolescents who started puberty blockers around the age of 12, like Valentine, De Hinge in the Netherlands. Sorry for garbling my Dutch there. And most famously, Jazz Jennings in America. These apparently confirmed that one could truly change sex as long as endocrinological intervention was started early. One other factor on the demand side was the sort of positive feedback loop that was created by puberty suppression. So the availability of blockers made it feasible for the first time to socially transition a child before puberty. Of course, it had not been possible before then. Jazz Jennings, for example, was socially transitioned at the age of 5, was enrolled at primary school as a girl at the age of 5. And then, of course, once the child becomes socially transitioned, then, of course, puberty in the wrong body but really does become an existential, social, as well as a physical threat. And so it's that kind of positive feedback loop between the availability of blockers and social transition, which I think is very important in increasing the demand from parents and children. So those are some of the reasons why the Dutch protocol was adopted in so many countries, despite the lack of empirical evidence.
Thank you so much, Michael. We're before time. Wow. So we have now a 20-minute time for a discussion and a debate in between the 5 speakers. The idea is like for you to answer the question on how could these progresses in your pioneering countries impact the rest of the world? How do you think that the CAS report is going to spread, and how will the country react to that?
Could I answer firstly? Because I would like to rephrase this question. How has the progress in our countries affected the rest of the world? Finland was the first to adopt a precautionary approach, followed by Sweden. As I mentioned, the reversal took place in the spring of 2021 and was reinforced by SBU's systematic review published in February 2022, which showed, as I've said, that hormonal treatment of children with gender dysphoria was in principle completely lacking in scientific support, and 2, the new national knowledge support from December 2022. An example of the influence that Sweden's new cautious approach has had internationally has come to my attention since 8th of May 2023, when I was contacted by a lawyer representing the US state of Tennessee. They had recently introduced a law for the treatment of children with gender dysphoria that was directly inspired by the new recommendations in Sweden. Now the law had been appealed, and the lawyer contacted me because he had read some of what I had written on the subject and wondered if I could be an expert witness for the state. Today, it has been just over a year since the Tennessee lawyer contacted me. During that time, I have provided expert testimony to 6 US states. In addition to Tennessee, Texas, Montana, Missouri, Florida, and Ohio. I have written 5 expert opinions and 3 supplemental opinions based on expert testimony from plaintiffs. Participated in 2 depositions as cross-examination by the prosecution, and provided testimony in 1 of the trials. Some of the cases are closed and they won. Some are ongoing.
Yes, Rita.
just associate on from this, I think that the most important thing is to gather research evidence about what the treatments are working and how, and are there those benefits that are claimed. If there are very positivistic and enthusiastic claims of benefits, we have to evaluate if these benefits really take place. If there is a risk of any harm, we have to do scientific research to demonstrate whether or not this risk actualizes, and we have to inform about the scientific findings. Scientific publication, I think, is the key to spreading the accurate knowledge and helping health services to formulate their practices according to the best evidence. This should always be the nature of medical activities. Medicine has to correct itself by accumulating new evidence, evaluating the old practices against the new evidence, and evaluating the practices. This is the only way that medicine can appropriately provide health benefits to people and prevent harm. Myself, I have been trying to report about my observations in this field from the early beginning, because this is what I have always done in any field of my activity. I have published extensively in other fields of medicine as well, well, psychiatric anyway, but in psychiatry as well. And when I first observed in Finland that the patients were not similar than expected, and next observed that they were not thriving as expected, I thought it was my duty to inform immediately the scientific community about the irregularities observed and that the expectations were not being fulfilled. It took me really many years to understand that the scientific community in corpore did not want to hear it. It didn't occur to me that this field of medicine would not operate in the same manner as any field of medicine should, accumulating evidence and evaluating practices and correcting them. Nevertheless, I think we have to keep trying. The European Society for Child and Adolescent Psychiatry, the ESCAP, recently gave out a statement emphasizing that research has to be evaluated and judged by the quality of the data and the design, the data, and rigorously how well the research has been done in terms of scientific, the rules of collecting scientific evidence, not based on what is the conclusion. In this field of medicine, I have noticed that there is sometimes a tendency to publish conclusions that are wildly away from what the data actually has shown in the paper. This should not happen in any field of medicine. And I think that producing evidence, publishing evidence, and also keeping the discussion going on, that this field of medicine has to be treated like any other field of medicine, is the only way to making the healthcare balanced and appropriate, and make it to correct itself all the time. The scientific community should also incorporate together, condemn any personal attacks against researchers and any operating on the level of defaming researchers, spreading rumors about their background or personal qualifications or that kind of things. We should only focus on the scientific evidence. And this is unfortunately not the case in this field of research, and the scientific community is not standing together. The community is allowing aggressive and misinformation spreading demonstrations if they are themselves feel that they are on the side of being favored by those. This should be condemned in any way, whether or not the aggressive demonstration or defaming or all this kind of background noise is in favor of me or against me. I have to condemn it, and I expect the same from all the scientists.
Thank you, Rita. We're going to listen to Michael Biggs.
Yeah, just two quick remarks. I mean, one is that I think Rita deserves enormous credit for being the clinic which had adopted what seemed to be the best practice, then saw that the results were not as they were in the Netherlands, or at least as reported as they were in the Netherlands, and immediately published evidence to that effect and changed policies. And that's a real contrast with the Tavistock JIDs, who started this experiment in 2010. By 2016, it was very clear that the children had not thrived on puberty blockers. They were not getting the same results as the Dutch. And as a result, what they did is just simply bury the evidence. And they didn't, they would have, I really do believe that that would have never come to the light without me discovering There's some preliminary results and unpublished conference papers where they admitted that this wasn't working. And so there's a real contrast there. And I fear that there are other gender clinics in other countries which are following that Tavistock-GIDS model of not reporting negative outcomes. So I think therefore we get a very biased picture in the literature. The second point I just wanted to make is that the CAS review really has made a huge change. You can sort of feel it. I feel it almost in my university, so it changes a sense of whether it's respectable it's now sort of respectable to question that, whereas before it was just being transphobic and bigoted. And I think the very fact that Rita and I were just at the Royal College of Psychiatrists International Conference in Edinburgh in Scotland, and there was, we were on a panel. Obviously, there were attempts to get that panel taken down, but I think there were maybe a few years before it would have succeeded. We would have been cancelled, but I think because of the CAS review, and CAS was one of the keynote speakers invited to present at the conference, we had that sort of air of legitimacy, even though the vast majority of the questions that were asked on the conference app were extremely hostile to us, including what were we doing to celebrate trans children and trans rights during Pride Month? That was one of the questions in a scientific conference. Right? What are you doing to celebrate trans children and their rights? And that was not from a graduate student or some graduate student. That was from someone with a quite high up administrative position in the National Health Service. And that was the quality of their question. So I think the CAS review has really, really made a difference. And I hope it makes a difference, and especially in other English-speaking countries as well.
Thank you, Michael. Would you want to say something? And David also.
Yes, well, I agree with Gatiala that it's important that the scientific community is self-correcting. When I'm looking to the Netherlands, I'm quite pessimistic because it's extremely hard if you are the Amsterdam clinic and you've invented the protocol and you've done it that way for 20 years. I mean, imagine that then you will admit that after all the evidence was too weak. I would think that's hardly impossible. And I think we also can observe that so far the biggest and quickest change has come from health authorities stepping in, starting investigations, starting to do systematic reviews, right? These are neutral, and these are looking with a fresh perspective, and they all come to the same conclusion, which is that the evidence is too weak and that we should become much more cautious. So I think that it's quicker to advocate for health authorities stepping in and to do what the scientific community should have done itself already for years. And in that respect, I think it's quite good that in the Netherlands, the parliament has voted for a motion to ask the government, to ask our health council, which is the highest advisory council in matters of health and public health for the minister and the parliament, to come up with an advice on pediatric gender care, with the question to which extent current Dutch pediatric gender care adheres to the health legal framework in the Netherlands. And they will write a report, the Health Council. The work should probably start this year. And my hope is just that the outcome will again be the same, which as so far, which is that the evidence is too weak and that we should be much more cautious.
I think Rita wants to say something else.
Well, I just wanted to add to this that the health authorities, of course, cannot operate without scientific knowledge. So the health authorities are one audience who needs to obtain the most recent and itself correcting scientific evidence. I kind of considered them as a part of the scientific community in a way. So health authorities must not operate either on base of feelings or political aspirations, but they are one of the part parties who need the compiling evidence or to base their activities on.
Thank you.
Yeah, I definitely
Oh,
agree. And I think that currently already the state of the evidence is quite clear.
David, would you like?
I feel that the stress upon the need to assess evidence to be objective, rational, is to be very, very much supported. But also, historically, there have been repetitive and continuous problems in maintaining those standards. And maybe it's better in some countries than in others. But, for example, if you think of the history of psychotropic medication, many would argue that the evidence is extremely poor. But this has very little impact upon people prescribing, for example, antidepressants to people for all of their lives. So this whole area of psychiatry, I think, is quite problematic in terms of being able to stick to this absolute necessary assessing the evidence. And therefore, I think it does need some kind of external monitoring as well. Also, the other thing I just wanted to mention, I mentioned very briefly before, is that I'm not saying this argument is being made here, but it is made elsewhere. We need the evidence, so we need to do a proper research with a randomly controlled trial. That sounds so scientific, and I think it's completely unethical. First of all, it's unethical, because normally these kind of trials are being done on children who are in danger of their lives, for which a new drug has been found, and which it would be right to try it. That's not the situation here. There's no evidence the drug is helpful. There is evidence that it's harmful. There's a lot of evidence that these children managed in a different way will grow out of it. And certainly we don't know which children will change their minds and which won't. To subject children to a clinical trial, I think, again, would be an ideological moment, not a properly scientific one. There's absolutely no reason to do that. I feel quite strongly about that. It sounds so scientific. And lastly, I don't think it's practical, because any child would know if they were on the puberty blocker or not, and therefore, the likely placebo effect will be massive. So it's impractical and unethical.
Thank you. Because we do have oh, you wanted to say something else? Yes. All right. Sorry.
Firstly, I totally agree.
Okay.
I don't think it's ethical to do those studies. Yeah. You can't do them, no. But then I would like to say I am an incurable optimist, and I am optimistic about the future of this issue because the debate began just 5 years ago.
That's true.
And in all the Nordic countries, in United Kingdom, in 25 of the states in United States, they have adopted the precautionary principle in only 5 years. That's fantastic.
Thank you for ending on an optimistic point of view. We were just wondering if we had a bit of time, Céline, for one question from the group. Oui.
I mean, we have no discussion with the audience. That's a shame, isn't it? Oh. Well, they have.
So, Jean-Louis, Magali.
Oui, enfin, non, si on n'a pas le temps, on peut reporter peut-être tout à l'heure. Alors, oui.
Maybe we can wait until later. Good morning. First of all, thank you. Just a minute. We want to give all the panelists time to put on their headsets. I just wanted to thank you for this international symposium. I think it's important to have a meeting like this because we need to get together with experts from all over Europe, because I think that there's also a key question which has to do with the European Parliament and the impact of this on our societies and on the fundings of all gender-related issues. And so, hence my question. Could we think of a group of experts who would get together in a working group that might lobby the European Union and be used as an experts group that would present their ideas and their criticism on this idea, because there's a lot of lobbying, a lot of influence in the European Union. So could we maybe have some kind of a European observatory or a European group of experts on gender issues? Thank you.
I would just comment, it was a great idea, of course.
Vous m'entendez? Alors, j'ai une question pour Madame Caltiela.
I have a question for Rita.
Depuis 2020 que les traitements hormonaux ne sont plus disponibles.
Hormone therapy is no longer available in your country since 2020. So trans activists claim that young people commit more suicide because they don't have hormone therapy anymore. Have you noticed an increase in the number of suicides since you've stopped providing hormone therapy?
Firstly, hormone therapy has not been stopped completely. It is advised that it is available under strict conditions and after a careful case-by-case evaluation and the personal, individual assessment of needs. Secondly, we have never taken a total U-turn. We were never enthusiastically and liberally prescribing, therefore we needed not take a U-turn when the accumulating evidence suggested that there really needs to be more caution. It has rather functioned in preventing from things going to highly low threshold interventions. There has not been any increase in youth suicide in Finland. Actually, the suicide numbers have been on the decrease for decades. You might expect actually that if this was the case, that there were lots of young people in earlier decades who never were able to express their feelings of gender dysphoria or trans identity, which would put them at higher risk of suicide, then you would have seen a number of suicides in previous years instead of now when there are also other treatments. My research group has also demonstrated that completed suicide is extremely rare in this population. We have published a paper which I didn't have time to put in my presentation, but you will easily find it in Medline, and we have demonstrated that despite that it is commonly cited that transgender identifying young people in the population as well as among those presenting with gender dysphoria in clinics, a very high percentage present with suicidal ideation, then must always keep in mind that suicidal ideation and completed suicide are very, very separate entities. Completed suicide is also rather rare, rather rare among psychiatric patients, but suicidal ideation is very common in all kinds of adolescent psychiatric disorders. Our study also demonstrated that in addition to that suicide was very rare, it was actually explained by severe psychiatric treatment needs. So it is severe psychiatric disorders that are the main risk factor for completed suicide, not gender dysphoria in itself. When we compared the people who had contacted for gender dysphoria to matched people in the population, we were able to demonstrate that it is the need for specialist-level psychiatric treatment that is the main explaining variable for completed suicide. Also, further, we demonstrated the number of suicide was so small that we couldn't go to very detailed stratified analysis and present suicide figures for different groups because they were so rare. But in the aftermath of the publication, we demonstrated first that neither those gender dysphoria patients who had proceeded to gender-affirming medication nor those who had not differed from the population controls as per, regarding suicide mortality. And later we have written, and we will see if it will be published in the aftermath in the discussion, we were allowed to give out the information that within the gender dysphoria group, the suicide mortality did not differ between those who had proceeded to medical gender reassignment and those who had not. Numbers were very small, but fortunately numbers were very small, and I am happy that we cannot do more stratified analysis because so few people actually suicided. That was a national study over 3 decades, and maybe in some bigger country you can do more detailed analysis, but I am happy to emphasize that suicide is really rare in this population. Suicidal ideation is a separate entity from actual suicide mortality. Suicide mortality has not increased in Finland. It has been on the decrease. There is no suicide crisis in our population, and not in general, and not related to gender identity.
Oui, nous allons donc, alors, pendant que chacun va regagne sa place.
Now, while we are asking all of you to go back to your seats, we are going to welcome Claude Habib. So, dear colleagues, can you please ask you to leave the rostrum? And we are going to have Claude Habib coming over here. And in the meantime, I'd like you to pay attention to a voice that we're going to hear in this room.